I am going to go ahead and kick us off and get started. First and foremost, welcome everyone for joining. We have probably the most well-attended and the highest number of registrants for this webinar that we've ever had at BCRF, and a lot of that has to do with last year. As we host these periodically, we did a survey, and this was by and far the topic that people were most interested in hearing about. So thank you all again for joining. We're going to get right into it because we have this incredible group of speakers and we want to make sure to use all of their time well and ask all of the questions that we're all thinking about. So we are kicking off Women's Health Week with what is poised to be a great discussion with leading experts from around the country. I'm also very excited to share that as part of our kickoff, just this morning, we announced the official launch of two brand new resources on our website called About Breast Cancer and the Breast Cancer Glossary. We know that the vast majority of people receive health information online, and the younger you are, the more likely that is to be the case. So, as the world's largest private funder of breast cancer research in the world, we are thrilled to be able to provide women with reliable and accurate resources on their breast health. So if you're just looking to understand your risk, navigate a new diagnosis, or just figure out what are dense breasts, you can find research-backed information direct from BCRF and learn about the latest that we're doing to study that specific area. Okay, so now speaking of research-backed information, we're here to discuss an alarming trend that we've seen for over a decade now. Breast cancer incidence has been steadily climbing. That's across the board, across all ages and ethnicities. But the steepest rise has happened in women under 40. And in fact, women under 40 saw twice the rate of rise as women over 40. I mean, that's scary to hear. And as someone who is diagnosed at the age of 36, I very much am part of that trend. But just 2 weeks ago, a new study unveiled at the AACR meeting reported that between in a 10-year period between 2010 and 2020, there was an overall 80% decline in deaths from breast cancer in women ages 20 to 49. So while improvements were seen across all racial and ethnic groups and breast cancer subtypes, the study also emphasized the need to address persistent disparities, particularly among non-Hispanic Black women, to ensure equitable health outcomes for all, right? So what does this mean? What we're seeing is that treatments are working. The science is working. Rapid advances in research are having an immediate effect on improving outcomes. But it bears mentioning that we are still at a critical inflection point because as incidence rises, most rapidly among younger women, there's still no cure for metastatic breast cancer. Again, I'm going to mention that life-threatening disparities persist, and we still lose women to this disease every single day. So our work is far from over, but especially now, these results serve as just undeniable evidence that research is the key and it works. So I'm pleased to welcome our speakers today, Dr. Virginia Borges from the University of Colorado, who's an oncologist and expert in young women's breast cancer, metastasis, and immunotherapy. Dr. Lola Fayanju from the University of Pennsylvania, who's a breast surgeon and health equity researcher focused on outcomes, disparities, and access. And our very own Diana Schlematinger at the Breast Cancer Research Foundation, who's our scientific program manager on our research team. So let's kick it off. Dr. Borges, your research focuses heavily on the unique biology of breast cancer in younger women. Now, I'm going to ask you two questions, which let's start off with why? Why are we seeing this trend? What's driving these increased rates of diagnosis? And what are some of the key differences that you've discovered between breast cancer in younger versus older patients?
Thank you, Sadia. I would say we know one reason why we're seeing an increase in young onset breast cancer here in the United States and globally. We've known for a very long time that all women, no matter how young or old they are when they start having children, face a period of time where they actually have an increased risk for getting diagnosed with breast cancer by virtue of having had that child, which, if they get a young start, crosses over and then becomes protective against getting breast cancer when they reach the more common ages where we see it diagnosed 55, 65, 75, et cetera. For many decades now, women globally, not just here in the US, have been delaying the age at which they are starting their families, and that increases the likelihood of getting diagnosed during that time frame. So the connection between childbearing is one, and the fact that women are making this life choice to have their children at later ages is likely contributing to why we are seeing more cases. However, there is also a lot that is not known. We are seeing an increase in women who have never had a child getting diagnosed and women who are in their 20s getting diagnosed. So even before the age at which we would have thought, even in the past, that might have been the common thing to be doing. And the reasons for that get doctors and scientists into a lot of hand waving about the environment and things we don't quite understand. All of us were an egg in our mother when our mother was an embryo in our grandmother. And so this could be things that generationally our older relatives were exposed to that aren't impacting us in a direct way we can identify, but are impacting maybe how our genes are expressed and in combination that are predisposing us to getting um, more than one cancer at a younger age, but in particular breast cancer at a younger age. And of course, things in the environment, the forever chemicals. Is it because we started using nonstick pans in the 70s? We just don't know all of those answers. In terms of what are some of the key differences that we know about breast cancer in younger versus older patients, in general, we know that women who get diagnosed when they are younger are more likely to have a breast cancer that is hormone receptor negative or positive for this gene called HER2. To be clear, no matter how old a woman is at a breast cancer diagnosis, most of the time those cancers will be hormone receptor positive. But the ratio is different when we look specifically at our younger women, with them having a higher number of these more aggressive subtypes, cancers that are going to be more likely to cause problems. Also, we see a different frequency amongst the racial backgrounds for women who are diagnosed in the US who are younger versus the more common postmenopausal ages. We see that the ratio of women to color is higher in comparison to Caucasian women, where when you look at postmenopausal breast cancer, that flips quite a bit. In my own research, we've focused on the interaction with a woman's reproductive history. So if a woman has chosen not to have a child or has not yet embarked upon having her children, her risk for developing metastatic recurrence over the next 5 to 15 years is less when she's diagnosed for breast cancer than for a young mother who gets diagnosed with a child under 10 at home. And when we see these breast cancers, we call them postpartum breast cancer because of this increased tendency towards the subsequent development of metastasis and death. We found that in particular for women who get diagnosed when their children are under 5 at home, that's a very high risk group. But overall, women who get diagnosed under 35, we call them very young at diagnosis, face these higher risks too. When you compound the very young age at diagnosis with them being also in that postpartum definition, we see that's where things even look the worst. So it is important to understand a woman's reproductive history at the time of her diagnosis, as well as just the fact that she's in one of these younger age groups.
Mhm. Well, what I'm hearing is number one, that this is so complicated, and there are so many reasons why we're seeing this trend, and it's been happening over a long period of time. And I think it's also so fascinating that we're talking about this concept of what you just mentioned, this idea of postpartum breast cancer when um, yesterday was Mother's Day, and we're talking about younger women who are at increased risk within the 10 years after giving birth, at an elevated risk. And I happen to fall within that window. My son was 4 when I was diagnosed at the age of 36. So I happened to work at BCRF and knew to pay attention to my body. And that's how I found my own lump, which is also incredibly common for younger women under the age of 40 who are not getting screened, right? 80% of younger women find their own lumps, which I did, and thankfully knew to keep an eye on it. I think something else that you mentioned that I wanted to underscore was just the how younger women face not just more aggressive subtypes of disease, but also are usually typically diagnosed at later stages just because, especially if you're under 40, you're not being screened. So I want to get into all of this, but I will say younger patients also face all of these unique challenges. There are the number one concern when we're talking about postpartum, but you mentioned this rise in women who've never given birth. Um, but just the unique uh, survivorship challenges when we've heard that fertility is the number one concern for patients under 40 when they've been diagnosed, only second to surviving, right? So there's a really complicated issue when you've been diagnosed particularly young. But Dr. Fayandru, you've done groundbreaking work on disparities in breast cancer outcomes. So what inequalities do younger patients, especially women of color, face when it comes to diagnosis and care?
Well, thank you so much for having this panel to address this pressing issue. So with regards to the disparities that exist in breast cancer has already been described. There is this inversion where postmenopausal breast cancer, you're more likely to see amongst white women. Premenopausal breast cancer, more likely to see amongst Black women. That is, Black women are more likely to be diagnosed before the age of 45, in addition to being more likely to be diagnosed with triple negative breast cancer. Again, all of these kind of factors that make it more likely that you'll be diagnosed at a young age before you've begun regular screening and with a cancer that's more biologically aggressive. And so we know that actually in the United States, relatively speaking, there is racial parity with regards to screening participation among women between the ages of 50 to 74. That is, Black women, white women, Latina women, Asian women are basically going through mammograms at around the same rate between 50 to 74. But again, as I just mentioned, we know that Black women are more likely to be diagnosed before they begin routine screening. So one of our challenges is one, helping all people know the kinds of things to be aware of that led to your own diagnosis. That is, don't ignore a lump. Don't think that you're too young to get breast cancer. In addition, knowing who to go to, that ideally not going to the emergency room, but going to a primary care provider or an OB-GYN, should you have one, is also very important to getting your care established. But perhaps one of the most important things that we are not doing for women of color is identifying who's at elevated risk for breast cancer. The truth of the matter is that we are less likely as women of color to know if we have inherited a mutation from one of our parents that puts us at increased risk for breast cancer, or to even have other risk factors, including dense breasts, that might put us at increased risk for breast cancer, that we might be starting surveillance with MRIs at a younger age. So we're less likely to know if we have a gene. We're less likely to know if we have other factors, including family history, that, if entered into a risk calculator, might make us more aware of the fact that we need to start earlier surveillance. And so to that end, we published a paper a couple of years ago in the Annals of Surgical Oncology, where we emphasized that it would be incredibly important for all women to have a formal risk assessment about their risk of breast cancer by the age of 25. That can be performed by any physician. In fact, patients can even do it themselves if they're sufficiently well informed. And it will allow them to advocate for then getting an MRI at a younger age, but also to become plugged in with a professional who can help guide them through those rather uncertain years prior to beginning screening initiation at 40. So again, 40 is when you begin screening if you are average risk. What we're not doing a good enough job is identifying who's at elevated risk and therefore should be getting screening at an earlier age. One other point is that even the risk calculators we have are likely doing an insufficient job at identifying Black women and Latina women and Asian women who are at risk for breast cancer because these calculators were largely developed with less diverse populations. And so another area of research that's very important is how to do a better job identifying women of color at being at elevated risk so they can begin screening participation at an earlier age.
Mhm. Thank you. And I think that's so important. A lot of us have been hearing Olivia Munn talk about her diagnosis. She talks a lot about that risk assessment calculator that you just mentioned. There's the Tyrer-Cuzick model that you can just Google, find it online. There are other models that physicians use as well. And I think it's so interesting what you just said, because I did the Tyrer-Cuzick risk assessment and it put me at, a very low regular risk, but guess what? I still had breast cancer. So my risk was 100%, not 13% as the average. So I think something to keep in mind is that these risk models are great if they give you information. But if they don't put you at an elevated risk, that's not reason to say, done, I'm good, I don't need to worry about it. It's something just more information is powerful, but it doesn't mean that you can ignore your breast health. So
Yeah, and to that end, I just want to say that for the other clinicians in the room, listening to patients, the number of times I've had, my youngest patient was 17. She was 17 at diagnosis, did not have a mutation. But I think the number of times I had patients diagnosed in their 20s who no one listened to them for a year, I can't even count on two hands. And so that is to say that we need to listen to our bodies, but our clinicians need to listen to us. And that's also very important.
Mhm. You're talking really importantly because it's two levels of education that need to happen. There's the medical establishment and the healthcare providers that need to sort of understand the elevated risk and the changing trends, and that it's no longer acceptable to say it's impossible, it can't be cancer. But also on the patient side, being empowered to advocate for yourself so that if you present with a concern, you don't let it go until your concerns have been adequately addressed. And so that's really what advocating for yourself to me means. Diana, we just talked about, the rising rates of breast cancer incidence in younger women, but also this incredible study showing improvements in outcomes, which gave me a tremendous amount of hope. Can you talk to us about why we're seeing such improvements in outcomes?
Yeah, absolutely. And I just want to say thank you for inviting me to this important conversation and for the question. So thanks to research, we have more targeted therapies that are contributing to precision medicine than ever before. Over the last decade alone, there have been 17 new drugs for breast cancer. I'd like to highlight just a few examples that I think have really moved the needle over the time frame of the study that you mentioned at the top of the webinar. So firstly, the adoption of CDK4/6 inhibitors for hormone receptor positive, HER2 negative breast cancer. This is the most commonly diagnosed subtype, which is often more aggressive in younger patients. So these really work by blocking the activity of key proteins that regulate the cell life cycle and can slow and stop the growth of breast cancer cells. Secondly, I'd like to highlight the emergence of antibody drug conjugates for HER2 positive breast cancer. These are a type of treatment that deliver an anti-cancer drug directly to the tumor, in this case, the HER2 positive tumor. And then thirdly, PARP inhibitors for some triple negative breast cancers, which of course younger women are more likely to be diagnosed with. So these work by blocking an enzyme which helps repair damaged DNA in cells. I just want to further note that even more recently than in the time frame of that study that you mentioned, Sadia, doctors have even more treatment tools for triple negative breast cancer, which is promising, including an immunotherapy and an antibody drug conjugate. So these are just a few of the advances in precision medicine that have contributed to improvements in outcomes for younger women. And researchers are, of course, working tirelessly to pursue other treatment options to continually improve outcomes, not just in younger women, but in all women diagnosed with breast cancer.
I think one of my favorite statistics that we talk about a lot at BCRF is the fact that there have been more novel therapies, these classes of drugs that you just mentioned, CDK4/6, ADCs, in the past 10 years than in the 30 years prior combined. So, when you talk about sort of this snowball effect where it's becoming an avalanche of, we're seeing the results in real time, and it's especially promising for younger patients who have more aggressive disease. And I think what's interesting is that a lot of younger patients who are more likely to have genetic mutations like BRCA mutations, that's what you were talking about, the PARP inhibitors, right? And so I think that's what's really fascinating about all of this. It's that treatments are getting better and better. We're doing better at getting to treatments. But what Dr. Borges mentioned earlier was, and Dr. Fayandri both mentioned, how do we do a better job of identifying those at high risk when they're not being screened? Dr. Borges, I'm going to turn to you. You've spoken about postpartum breast cancer being especially aggressive. What are the biggest unanswered questions about this subtype, and where is the research headed? I'm going to throw one more question at you because we got this question. I think it's really important, is also the role of birth control when it comes to risk in younger women.
Oh, no complicated topics today, eh? I'm very glad we're covering all of these because I think this is incredibly important information for everyone listening to understand. And I just have to echo what Dr. Fianju said earlier. I too see too many young women who were not heard by their providers. And I think there's some unfortunate statistics to say that women in general are not as well heard in the medical world, even when the doctor is also a woman. So we must be encouraging our young women as they come into their adulthood to understand their health, understand their bodies, and be capable of advocating for themselves to get the medical attention they need, in particular when they're presenting with breast concerns. So before I get into the postpartum question, I'll answer the OCP question. So some of the strongest data I know of comes from the AMBER Consortium years ago that looked at the interaction between women who are using birth control and then being at risk for developing breast cancer. And it does increase the risk, in particular for both estrogen receptor positive and triple negative, and for women of all racial backgrounds. The AMBER Consortium specifically looks at the disparities of breast cancer and breast cancer onset and what is more likely to happen in Black women versus white women. Now, that doesn't mean women shouldn't use contraception, because we have to have control of our fertility and we have to be able to plan our lives. But understanding your personal family history, your risk from that family, and what other things you can do in life to mitigate your risk, such as exercise, minimize the use of alcohol, can allow a woman to make informed choices as she goes forward. And there are some forms of birth control that don't have hormones and lower the risk, such as a copper IUD. Well, I should say doesn't increase the risk of copper IUD. So again, these are the types of detailed information we need our young women to be getting as they're making their reproductive choices. In terms of postpartum breast cancer, there are many unanswered details, especially given the fact that the majority of the data to date has come from cohorts like mine out here in Colorado, dominated by Caucasian women. And myself and others are definitely working to address that with BCRF's help, if I may say so. I would say one of the biggest things that we need to figure out is how a woman gets from the denominator of the millions of women who are going to have children in the United States each year to the numerator. We expect there'll be about 18,000 cases of postpartum breast cancer per year. And that number is derived from looking at the big statistics that show about 36,000 women under the age of 45 will get diagnosed. And then when you look at my research and others, it's about half of those women who will meet the criteria of being diagnosed within 10 years of their most recent childbirth or one of these postpartum breast cancers. And we've not, other than having that child and the age of the mother at the time of her first childbirth, we don't really know why someone would end up getting a postpartum breast cancer. So it makes it hard to establish increased screening recommendations or increased awareness that is tailored to those at highest risk. We just know that our young mothers are at risk. I would say the other most important issue that we have yet to identify is, what can we do to get rid of this increased risk? Right? It's all well and good to tell someone they have an increased risk, but unless the doctor can also turn around and say, and here's what we're going to do about that, we have not fulfilled our requirements. And I do want to emphasize that though we are talking about postpartum breast cancer and young mothers facing an increased risk, the overwhelming number of those women will also still be cured with today's advances, particularly what Dr. Schlaminger just reviewed. Most of the data that we've published so far comes from women who were treated, certainly before 2020 and even many before 2015. And as you mentioned, in the last 10 years is when this explosion of advances has really arisen. So whether any of our newest tools will help eliminate some of this postpartum effect in our outcomes moving forward is to be determined, because you have to have time and follow-up to know that. But also my team and I and others around the world have been working towards identifying biomarkers that could tell us who that gets diagnosed with a young onset breast cancer, postpartum or otherwise, does face these increased risks for developing metastatic disease, and therefore can we develop new treatment strategies that will get rid of that. And importantly, postpartum breast cancer is finally starting to get the attention it needs, evidenced by today's webinar, but also the specific parity data needed to be able to identify the differences in young women's breast cancer, such as who is nulliparous and what is the timeline between a woman's diagnosis and her most recent childbirth, have only recently started to be incorporated into larger clinical trials. So there's a big neoadjuvant study or treatment before surgery study in the US called the I-SPY 2.2 trial, run across about 40 different cancer centers spread around the US. We are now getting that data in women enrolling on that clinical trial, and also a great big national cooperative group clinical study that will be defining best practice in premenopausal breast cancer called the Offset study, is also capturing that very specific piece of parity information. So while it'll be a long time before we will know exactly how that data informs the results of these major clinical trials, at least we are now getting these groups to get that piece of information that previously had been missing, and I hope other groups will follow suit. Lastly, I'll just say that I've been working with my research partners for a long time, decades, on figuring out a prevention strategy, but that needs more evidence to know if it's going to have legs. The idea is that since we can identify that women who are postpartum have this increased risk, is there an opportunity to identify an intervention that could be taken when that woman is weaning her child or post-delivery, if nursing's not going to occur, that would actually block what we think are the reasons why these cancers arise during the key timeline. And that could lead to the changes in a woman's breast that causes postpartum breast cancer and their aggressive behavior. So we do think there is the potential, with a lot more research, that one day we could literally eliminate the onset of postpartum breast cancer, or at least prevent it from having its increased risk.
Mhm.
Mm.
I mean, it's all, as a patient, I will say it's scary. Like, it's so scary to hear a lot of this, especially when you're young and you're thinking about your journey into, motherhood, and how being a mom is hard enough. And so now having to also worry about your breast cancer risk while you're taking care of little humans, that's really tough. But I want to talk also about women who are not postpartum, younger women diagnosed. Dr. Fyanji, you mentioned this, younger patient you had at the age of 17. I'd love to hear about your experience as a breast surgeon and how you guide patients, specifically under, younger patients that haven't had children and are sort of facing this question around fertility, and where do you see, how do you see, one of the things that you talk about a lot is data-driven care, and how do you see the future, especially with this sort of advent of AI driving some of the changes or decisions around treatment? Sorry, that's a very complicated question, but let's start with sort of how you guide patients that haven't had children, and then we'll get into sort of some of the ways that you see treatment decisions evolving.
So I'm very lucky that at University of Pennsylvania, I work in a multidisciplinary team, such that whenever a patient presents with breast cancer under the age of 50, we schedule them with a medical oncologist and surgical oncologist upfront. And that multidisciplinary coordination, I think, is critical, increasingly critical in breast cancer, because about a third of patients are receiving neoadjuvant or preoperative systemic therapy. But even if ultimately the decision is to have surgery happen first, because there are questions in young women of fertility, of care coordination, of reconstruction, getting everyone on the ship to work for this patient's care right away is very important. So in coordination with my medical oncology colleague, first of all, I start by acknowledging that this patient is in a difficult situation and helping them just realize that they're not alone, that this is very much something that increasingly is happening, and I connect them with resources for other young women with breast cancer. I also assess whether or not they want to have children, because not everyone wants to have to bear their own children. And if they want to be a mother, there are different ways to be a mother, and I want to acknowledge that as well. I find out what their life circumstances are, if they're in a heterosexual relationship, if they're a gay relationship, if they've always thought about surrogacy, to understand again what is consistent with their already planned goals for childbearing and their life circumstances. And then we immediately reach out if they decide that they want to bear children from their own, biological, their own DNA, then I actually work with an REI team we reach out to right away in order to figure out how we can, again, consistent with the patient's values, work to preserve their fertility. So patients have a range of things that they might want to do and a range of commitment to having their own biological children. Some people, it is an absolute priority, in which case those individuals who have partners with whom they already know that they want to receive sperm from that individual, they may actually choose to create embryos upfront right away in order to allow for that to happen. There are others who want to preserve their eggs because they may not be in a partnership, and so they at least want to freeze their eggs to have that be available for them in the future. There are others who would like to have their own children, but don't necessarily want to go through all the additional hormonal treatment that's associated with being able to engage in fertility preservation, which again is not without risk theoretically. And so those individuals might say they're fine with just, for instance, receiving Lupron, which is a form of ovarian suppression that can preserve fertility function following chemotherapy. So those are kind of the different strategies that can be taken, as much as embryo creation, as little as Lupron administration, or just simply saying, we'll see how it goes. I'm young. I'm hoping that even if I have to go through chemotherapy, my body will recover. And then again, once we decided what the treatment sequence is, if the person is someone who needs to get preoperative systemic therapy, we typically have about a 2 to 3 week window to try and get those processes online as soon as possible for fertility preservation. If they're having surgery first, we have a little bit more time to play with, though our goal is still to try and have treatment completed, at least the first treatment started within 60 days of diagnosis. I think the other things to think about with talking with young women is they may also want to think about not engaging in fertility preservation or planning a family at that time. They often want to know when they can start thinking about having a family after all their treatment's done. And a very important trial that was published by Ann Partridge, who's also a BCRF funded investigator, is the PROMISE trial, which looked at how long women who are on endocrine therapy for hormone receptor positive breast cancer after an acute diagnosis, how long after that they can actually consider conceiving. And it seems to be that it should be safe for them to do that after 2 years of endocrine therapy, which is an incredibly important thing to know for women who've already delayed childbearing because they've been going through breast cancer treatments. That is to say that we really provide a multidisciplinary approach that thinks not only about what's happening at the moment, it takes into account treatment sequence, but also provides them with some projection of what the future can look like should they choose to defer childbearing till after they've completed their treatment.
So I think in one of the things that I'm hearing from you also is that there are options, that there are options for younger patients, especially those that haven't had children yet, to pursue, especially given new data from BCRF funded investigator, Dr. Ann Partridge, especially for those that are already in treatment. But a lot of the questions I'm going to try to pepper in some of the questions that we're getting, because we're getting a lot of them, which is great. That means people are listening. But one of the things that people are asking are also around screening and what's happening when what's some of the latest? And Dr. Schlematinger, I know that for BCRF, we're taking a look at breast cancer in younger women and how research can address this very multi-pronged problem. I'm wondering if you can talk to us about sort of some of the latest in what we're doing to address this issue, specifically also when it comes to, for example, dense breasts and new technologies.
So yeah, thanks for the question. So dense breasts are certainly a risk factor for breast cancer in women of all ages, but it is more commonly observed, of course, in younger women, as you say. Importantly, dense breast tissue can obscure signs of cancer on a mammogram. So there are supplemental screening tools such as whole breast ultrasounds and MRIs that are already available to women with dense breasts. But of course, a number of researchers are working on better screening technologies. I'd like to highlight BCRF investigator Dr. Chris Comstock, who is leading the CMIS trial. So that's Contrast Enhanced Mammography Imaging Screening Trial to improve early detection of cancer while also reducing false positives in women with dense breasts. So this contrast enhanced mammography is a relatively new tool that is not limited by breast density. And early studies have shown that it improves the number of cancers detected by 70 to 80% compared to a conventional mammogram in women with dense breasts. And the exciting thing is that this trial is set to report its first results this year. I'd also like to highlight BCRF investigator Dr. Wendy Berg. She's assessing alternative methods of screening for women with dense breasts that could provide more precise results. This includes AI to enhance ultrasound. She's also very interested in investigating the sensitivity and specificity of 3D mammography alone compared to 3D mammography plus this contrast enhanced mammography that I just mentioned. So her research will help optimize screening procedures or screening practices to catch breast cancer earlier. Other new screening techniques may also be beneficial for women with dense breast tissue, and abbreviated breast MRI has been shown to have better cancer detection rates compared to 3D mammography among women with dense breasts. And abbreviated breast MRIs use the same technology as MRI, but take fewer images over a shorter period, which means screening time is shorter and less expensive. I think that the panelists have already illustrated the importance of better risk assessments, which I think is really key, and improved screening. These things combined will help shift from an age-based screening to a risk-based screening, which I think will benefit younger patients.
And I'm going to turn back to you, Dr. Fayandju, to speak also just specifically on disparities and how it shows up when it comes to screening.
Yeah, so as I already mentioned, we have in general racial parity with regards to screening participation for average risk women, with a notable exception being Indigenous women, actually. Native American and Alaska Native women have lower rates as compared to other groups. But where we actually also have a real problem with disparity is with follow-up of abnormal mammograms. So we published a paper showing that even at our diverse academic institution where there's abbreviated MRI and there's a real commitment to following patients closely, Black women are less likely to undergo timely resolution of an abnormal screening mammogram. So you go to the mammogram, you think it's going to be fine, but then it turns out that they want you to come back, and Black women are less likely to come back. And so there's not only that there's delays and an ultimate resolution, it means there's also delay in the subsequent biopsy that might be recommended. And sometimes there's no resolution. So that person walks away from the process out of fear. The other disparity that we've noticed is in the quality of screening tools available. So 3D mammography or tomosynthesis, we know is a much more sensitive and specific way to diagnose breast cancer. And yet we know that it is still not uniformly provided and available across the United States. It's less available in rural areas as well as in other types of areas where there is a relative paucity of radiologists and high quality radiographic equipment. That is to say that even that getting to the screen is not enough. What matters is getting beyond the screen if it's something abnormal. Also, what matters is the quality of screening equipment that's being used and a commitment by the screening team to following up with patients who have abnormal screens. The final thing I will say is that, again, in terms of assessing who's at increased risk for breast cancer, there's a distinction that needs to be made between quantitative and qualitative breast density. So Black women have historically, because density is associated with BMI, have been historically thought of as having less dense breasts, and therefore, based on that criteria, are less likely to be recommended to undergo MRI. But in fact, when you look at the quantitative overall amount of breast tissue, their density is actually potentially higher. And so it may be that we're not always incorporating all the right risk factors in the right way for different patients in such a way that we could potentially underestimate risk and therefore not allow people to be eligible for other types of screening tools. So in Pennsylvania, we now have a law that says that extremely dense breasts is a criterion for which MRI should be covered by insurance. But again, if you don't have that criteria, it doesn't mean that you are on an increased risk and you wouldn't benefit from that type of insurance coverage. We've also found that Black women are less likely to get MRIs, even when indicated. So again, there's a combination of the technology needs to be improved and it needs to be available to help people, then patients need to be actually, directed towards that technology and be able to take advantage of them.
I think we've all been talking about this concept of, when it comes to younger patients, how do we do a better job of identifying those at high risk? So pinpointing, finding those sort of needles in the haystack, because when it comes to, we're talking about these increased risk of younger women, but when you're looking at the general population, it's still fairly rare, right? I use this in quotes because to me, like, once you've been diagnosed, the word rare is meaningless, right? It like goes out the window. But having said that, I just want us to uh, be cautious in terms of how we're talking about younger breast cancer, right? Because it's still, again, fairly rare when it comes to the general population. Having said that, when patients present with symptoms, that's where I think we've also talked about the idea that it's no longer acceptable for doctors to say, like, don't worry about it, it's not cancer. One of the questions that we've got is, when it comes to screening, should we be screening earlier? Should we be screening earlier than 40? I think Dr. Schlematinger, one of the things that you talked about was the idea of improving screening technology. I think that when you look at the population-wide data, it's clear that screening under 40, that's not the answer. That's when we're overcorrecting for the problem, right? But with these trends, the research hasn't caught up yet. And that's what we're trying to do. We're trying to catch up by identifying high-risk patients, finding those needles in the haystack so that we can pull out those people and say, you are at higher risk and you need screening earlier. But that's what we're still trying to do. I will say that when doctors, I always say, like, our doctors are not out there just like callous about our lives, right? They're not just saying like, you don't need screening, don't worry about it, because they don't care. I think a lot of it also has to do with our healthcare professionals are wary of recommending screening when they know there's a high rate of false positives and letting patients undergo sort of unnecessary biopsies. So I think, Diana, one of the things that you talked about is sort of the improvements for dense breasts and sort of the screening technology, the hope we have for doing that, so that I think even doctors will be less fearful of that high false positive rate, so that they're more likely to prescribe screening mammography when patient, or a whole breast ultrasound when they feel confident in the results. One thing I want to talk to, the second part of that story is, once you've identified that high risk person, sure, they'll get more screening, but we're also working on interventions, right? So that we can prevent the disease entirely, right? So Dr. Borges, one of the things that you work on is also sort of immunotherapy. Can you talk to us a little bit about how immunotherapy might play a role when it comes to non-surgical interventions for high-risk patients?
Sure. I will start off by just sort of clarifying for everyone on the call, what is immunotherapy? Because this word gets tossed around a lot, and it's important to understand how it differs from the other forms of treatment for breast cancer. So at a mile-high level, breast cancer is targeted in a two-pronged approach. There's the local therapy, the surgery and radiation, which removes the tumor and it addresses the local area where the tumor was, lymph nodes, et cetera. And we know radiotherapy can impact what happens in the rest of the body as well. Where a medical oncologist like myself focuses is the systemic therapy, the medications that go throughout the bloodstream, whose target is to go after the hidden little cells that could have escaped from that breast cancer at the time it was diagnosed and be out there in a woman's body. And that's what we want to prevent from being able to set down roots and grow. So it's still breast cancer, but it's now in another organ. And that's what we mean when we say metastasis or spread of the breast cancer. All the medications you've heard mentioned today, the PARP inhibitors, the ADCs, are all very targeted to the cancer. They find those cancer cells and they do something directly to the cancer cell to kill it. Immunotherapy is quite different. So we know that in any person diagnosed with cancer, breast cancer included, there's something that the cancer cells are able to do that basically lulls the immune system into ignoring it. Our immune system, from the moment we are born, is structured to not attack anything that it recognizes as ourselves, but attack foreign things, viruses, bacteria, etc. Cancer is very sneaky because it has turned into basically a very bad medical problem, but because it was once upon a time a healthy cell, it still looks like self. And it has the ability of convincing the immune system, this is not what you need to see. What immunotherapy does is it basically removes the blinders from the immune system. So it can now, in one or more ways, recognize the breast cancer as a problem and turn around and attack it. So that's what some of the most recent advances in breast cancer have been, drugs that are called checkpoint block inhibitors. Just like the name says, it removes the block so the immune system can turn around and have an effect. Now, if you're going to talk about immunotherapy as a prevention strategy, those medications are probably not where we're going to land, because you have to have a tumor for it to educate the immune system about. But vaccines have been an emerging, exciting therapy, and that's where we can get into both the concept that vaccines can help treat people who have had a breast cancer, and we're now looking at preventing it from ever occurring again, or perhaps one day being a pure prevention strategy. 25 years ago, when I started my career, I was working on breast cancer vaccines, but back then we had so little knowledge about the details of the immune system. None of those vaccines were going to be successful. However, fast forward all these years, and with all of what we now understand of the different components of the immune system, how they work, how we can use them to prevent a cancer cell from establishing, there is the promise now that those targeted therapies could exist. In young onset breast cancer, for a woman facing that diagnosis today, immunotherapy is real time. So we've already talked about the fact that young onset breast cancer has a higher frequency of triple negative breast cancer, and incorporating immunotherapy on top of chemotherapy is standard of care. And that has been shown to be a very powerful 1-2 whammy against the breast cancer, and is markedly increasing cure rates from triple negative breast cancer. And we can also use similar drugs like that should a woman have metastatic disease or face a metastatic disease recurrence, to really have more impact against the tumor and to be able to keep that woman alive. And what's great about immunotherapy is, for many people, it doesn't contribute much in the way of side effects to what they would experience from chemotherapy or other treatments. There can be some complicated side effects that it can cause, most of which we're getting much better at managing as time goes by. But for example, I have women in my clinic with triple negative breast cancer who took some chemo on top of their immunotherapy, and have now been able to enjoy a period of maintenance on their immunotherapy. Yes, they still have to come into the infusion center, which is a big deal, but it doesn't have the side effects that ongoing chemo would have. And that's a game changer in triple negative breast cancer in comparison to the past. Now, there are numerous ongoing clinical trials that are incorporating novel combinations. We heard about the antibody drug conjugates and other targeted therapies, and they're being partnered with immunotherapy across all the subtypes. One of the more common subtypes in young onset breast cancer is dual HER2 positive and estrogen or hormone receptor positive, and that's getting special attention in these novel combinations as well, because those can be cancers where the fact that both are positive works against each other, and we're finding ways to get around that. So all of these breakthroughs about the understanding of the immune suppression, the new therapies that are here today, and the very high-end, even fancier immune therapies coming, are going to specifically benefit our younger women.
I think this is all so helpful for us to keep in mind, that we're not only looking at ways to better treat the disease, but we're looking at better ways to be able to step in before it takes root, and this concept of intercepting the disease before it has a chance, because no one wants to be in treatment, right? So we want to try to make sure that we're making a dent when it comes to incidence and diagnoses. So we have so many questions. We have about 8 minutes left. I'm going to try and talk big picture about some of the questions that we're getting. And for those who don't have their questions answered, remember, we have this incredible new resource on our website about breast cancer, and so many of these questions are answered right there. So I would encourage you to take a look as well if we don't get to your question. But we're going to do a little lightning round. Now I'm going to open it up to everybody here, so feel free to chime in. But there's a lot of sort of myth-busting questions that I wanted to pose to all of us. So as far as a lightning round goes, true or false? The COVID vaccine has an impact on increasing breast cancer risk and is part of the reason why younger women are getting diagnosed. I can sort of answer that question, but I'm going to open that up to everybody. But one of the things that I'll point out, we get this question a lot. I have a lot of young mom friends that are like, I got the COVID vaccine. Is that why it's happening? We're seeing it in younger women. One of the ways that I help address this trend has been happening steadily for the past decade, right? And so this is not the COVID vaccine has become available, what, in the last 2 years? En masse at the population-wide level we're talking about. So that's my first approach to answering, is that this is a steady trend we've seen for well over a decade, especially in younger women. So anyone else want to take that on or add anything to my answer there?
I will just say that there is no evidence for that at this time. What I will say is that a lot of women had delays in participating in screening and other types of care access because of the COVID-19 pandemic, such that they are more likely to present with a symptomatic or palpable cancer when they did present in the years after the pandemic's peak, when people weren't accessing healthcare. So I think that there is also that perception that occurred because care was delayed, that we were seeing some bad cancers emerge afterwards because they had not been addressed during the pandemic. In addition, the cancers that presented themselves during the pandemic were unusually bad because you only came for care for that in the middle of a pandemic if it was quite bad. So I was finding myself treating a lot of locally advanced cancers because those are the people who were risking presenting with a cancer in the middle of a pandemic and were presenting for treatment. One of the things people should be aware of is that vaccination in the arm, whether it's COVID or anything else, but particularly with COVID, can lead to what's called reactive lymphadenopathy. That is, your lymph nodes look bigger on that side on a mammogram or an MRI. It's just in the same way that because your lymph nodes are kind of outposts of your immune system, they get bigger during a lot of processes. So not only with the inflammatory and immune response associated with vaccines, but also if you have a bad cold or if you're having your period, you can have lymphadenopathy. And so people should not think just because they got the COVID vaccine, it's causing a problem with their lymph nodes. It's their lymph nodes doing exactly what lymph nodes do, which is mounting a response to this new immunologic information. And so what I have sadly seen, unfortunately, is too many people trying to pursue breast cancer treatment with things like ivermectin. That is the same thing that was trying to be used for COVID-19. Sadly, women are also trying to use for breast cancer. There is no evidence that that is effective. And one should recognize that there are no secrets in breast cancer that we wouldn't want to know about. We want to know when there is something that can work for all women. There is literally standing ovations in audiences at our conferences when a big drug is announced and there's evidence of significant efficacy. So that is to say, we're not hiding things from people. We want to cure as many women as possible. And COVID-19, fortunately, while it had many deleterious effects, does not seem to have been associated with the increased risk of breast cancer.
Mm-hmm. Yes, thank you, Dr. Borges.
Yeah, and I will just follow on with those thoughts, agree with absolutely everything that Dr. Fayandju just said. And the other thing that also was a trend during the pandemic was women put off getting pregnant because we knew that there was an interaction with higher risk of a poor outcome if a woman experienced COVID-19 infection while she was pregnant. And so we've already talked about how being a little bit older at the time you're having your children can increase the risk of getting diagnosed with breast cancer. But you were spot on, Sadia, when you were saying that this is not a new trend that correlates merely with the advancement of vaccines that were life-saving during the pandemic. I've been doing this for 25 years. I am not out of business. And so this trend has been going on for even more than just the past decade. It goes back in the reported literature beyond that. The other thing to keep in mind, and this is complicated research, but we know that the presence of viruses can actually predispose people to getting cancer. And there is evidence that if people get, when you look at the pandemics that have gone before, that then just in general, cancer incidences can go up in different populations. We don't know that getting COVID itself increases the risk of any cancer per se, but there has been evidence to show that cancer diagnoses in general are increasing on the backside of the pandemic. And is that because more people are aware of their health and coming in and getting diagnosed, or because just the presence of that infection and the immune challenge and inflammation that it caused in people's bodies are making this happen? But it's not the vaccine part of it that we're seeing for sure.
Mhm. Well, thank you. We have just a couple more minutes left, so I just want to first and foremost say thank you to our experts. Thank you so much for taking the time to answer these questions and really take a look at the research and the work that we're doing to address breast cancer for all women, but also specifically for this most vulnerable group of patients, which are younger women like myself, who are shocked, right? We'd never expect this kind of diagnosis to impact our lives. One of the things that I will say is there's so much opportunity for hope. Just that statistic around the improvements in survival to me just brought me to tears the day I heard it, because we live in this constant state of fear, and hopefully it's for decades, but it's a long time that we'll have to live with the fear, the ghost of recurrence in the back of our minds. But one of the things I wanted to address, because we're getting a lot of questions around also sort of modifiable risk factors for when it comes to not just reducing risk, but also reducing risk of recurrence for those of us who've had talked about, who've had breast cancer and been treated for it. Again, online, there's great resources for BCRF on bcrf.org to look at what those modifiable risk factors are. I think overall, it's maintaining a healthy lifestyle, right? So things that would improve your just overall wellness for any number of diseases also holds true for breast cancer as well. I wanted to just also ask my one question, because really to the doctors who see patients and they get asked, like, should I be taking, what supplements can I take to prevent breast cancer or to better make my treatments more effective? Do you have an answer to that when patients come to you and say, I'm taking these supplements?
What I typically say is that, the best evidence we have comes from clinical trials. And that doesn't mean that may not be a supplement, or some magical, source from the Amazon or from, that could possibly treat breast cancer. But until that's put through a clinical trial, we're not going to hang our hat on that as opposed to what has been and rigorously evaluated. In terms of supplements, I think a lot of women are vitamin D deficient. And that's a consequence of our spending less time in the sun. And even those of us who have origins from sub-Saharan Africa, we are getting less and less vitamin D, and are therefore more and more likely to be at risk for osteoporosis. And given that there is a known side effect of osteoporosis with some of the medications that are used to treat breast cancer, I think preemptive avoidance of osteoporosis for many reasons, breast cancer treatment aside, would be great. So I do encourage a lot of women to at least know your vitamin D levels and preemptively take vitamin D supplements. I think that's really helpful.
And I'll just follow on. I also support vitamin D as one of the supplements, and I do want my patients having their vitamin D levels checked, because deficiency and breast cancer are a bad combination. Beyond that, it really comes down to a conversation that is almost as much warning and my desire to protect the women I take care of from what I see out there in our world. So the supplement industry has become a very vital industry without really the evidence to go behind it to support what I see my patients being recommended when they are going to one of these clinics. We used to call it alternative medicine. Functional medicine is a latest buzzword. And we know that this long list, 20, 30 supplements, are not going to benefit our patient. There might be one or two in there that makes them feel better or have attributes. And the ask I make of my patients is to please discuss it with me. There are definitely some out there that we would not want them to take, either because it will have an interaction with the medications we're prescribing, or it could mimic estrogen in their body. Lots of reasons to be thoughtful about this. And also it goes back to something that Dr. Fianju really expressed a few moments ago. She and I work for an institution. We are salaried physicians. We get paid the same whether one of our patients ever comes back to see us again or not. When one of my women is putting themselves into one of these clinics where the person making the recommendations is going to directly financially benefit off of them buying those supplements from them, they really need to look at that carefully. You, Sadia, well articulated the fear of recurrence that all of our women, particularly our young women, have to deal with for decades of life, with the concern of what's going to happen to them and are they going to have the future that they always envisioned or wanted them for themselves. And that side of medicine really does kind of, or that side of the supplement industry does kind of play on that fear of recurrence, because doctors like us, we're honest. We committed to be.
Mhm.
And that isn't what you will see when you're looking at a website of testimonials, which are not evidence-based medicine, or just what somebody is telling you. So as we say in marketing, let the buyer beware. And I'd much rather my women, instead of sitting there on the internet looking through reams of pages of internet information about this, would put their shoes or sneakers on and go out and exercise, because that is the true supplement that prevents breast cancer recurrence and prevents cancer, breast cancer in particular. So when in doubt, go walk.
I love that. I'm going to do that today. But I wanted to, again, just reiterate that a lot of the information, if you didn't get your questions answered, they're on our website. We will send a follow-up email and try to include specific links to some that really get into sort of lifestyle factors and all of the things when it comes to prevention and preventing recurrence. I want to, number one, encourage you to follow. There was also a question around how do we know what information to trust? Again, we just launched a new resource, but I also want you to follow at BCRF Cure, because that's where you know it's research-backed information. Dr. Schlematinger, her team, and our team takes great pains to make sure that this information is accurate and research-based. So please do follow BCRF. Follow me, follow, and visit our website, please, to make sure that you are getting the most accurate information. Dr. Schlematinger, as someone who is knee-deep in the research, 365 days of the year, I want to end on a note of hope. And what are you most hopeful about for the future?
Oh, gosh. I think prevention, honestly. I think that one thing that we didn't really get to talk about, as you know, is all the modifiable risk factors and the importance of exercise and how you can live a healthy lifestyle in spite of all that's going on in your life. So I think that that's my biggest hope, is preventing from this disease from taking hold in the first place.
I am with you on that. And so thank you to all of our viewers who've come today. And I hope that you've taken away actionable steps that you can do in your own life to either prevent the disease from taking root or make your experience with the diagnosis better. And at least just knowledge is power. And I hope that that's what you've gained today. So thank you, Dr. Borges, Dr. Fianju, Dr. Schlematinger. We are so grateful for your time.